We'll be moving on to our next speaker. Our next speaker is Dr. Phillip Saigh. Dr. Saigh is a professor of the Graduate School of the City University of New York. He's also on staff at the Brooklyn VA Medical Center. He previously served as a psychologist at the American University of Beirut from 1977 through 1986. He has clinical and research interests involved in PTSD, and he's published more than 60 articles or chapters in this regard. He's also a fellow of the American Psychological Association and a member of the American Psychiatric Association that's writing the next book that will be looking at how we come up with our diagnosis, which is the DSM-IV, an advisory committee for PTSD. One of my things that I have the opportunity to say while I have is that working with Dr. Saigh has been very rewarding for me individually because of his expertise, and especially with working with traumatized children. Okay. With that, I present Dr. Saigh.
Thank you, Michelle. Good morning. It's certainly a pleasure to be here, and very glad that all of you were able to come out. This morning I'm going to be talking about a number of topics. I thought I'd like to start by presenting an overview of the history of PTSD, and I've prepared some slides which hopefully won't make you fall asleep. I'll also talk about the validity of the classification. As you know, when this classification was proposed, a lot of people in professional circles were opposed to it. And subsequently, is that the microphone? Oh, the average, okay, fine. Then I'll talk about a study which Ms. Simmons and I are conducting here at the VA involving the adolescent children of Vietnam veterans with PTSD. I'm going to share with you some of the preliminary data as well as some of the preliminary conclusions, and I will make a strong call for volunteers. I really need your help in this. Finally, I'll be talking about some problems which children have, and I'll be distributing material about things which parents can do in addressing childhood problems. So that's the agenda. To begin, the topic, as you know, is PTSD. Could we turn on a slide projector? Thank you. Okay, now, I use the abbreviation PTSD. Of course, everybody in the room knows what this means, but when I give a talk elsewhere, I'll have to explain it. We can try to raise the slide up. Can you all see it back there?
No.
No?
Okay. There you go. There you go. All right, good. Very good. Thank you.
No problem. Okay. To begin with, the word PTSD wasn't around until 1980. But if we look at traumatic events and their impact on people, we have a very long history of this sort of problem. In fact, the Greeks, Herodotus, described an account dating back thousands of years. And I was able to actually get a description from one Samuel Pepys, who not only survived the Great Fire of London, but the plague. And Mr. Samuel Pepys kept a very avid record of everything he did. And here he is recounting his symptomatology 6 months after the Great Fire of London, which, if we look at it according to the current nosology, the classification which we use to make a diagnosis, it's suggestive that the man may have had PTSD. And Neil Kreplin was a very early nosologist. He was a systemist and wrote some very famous and excellent books on psychiatry. And here we have a German expression, which I called German lady at 8:30 in the morning to try to pronounce it for you. I think she called it Schreckneurose, which entails really a fright neurosis. Again, this is a very old definition, 1896. But if you look at what the man had to say, it's rather indicative of the current PTSD classification. And we can go on. Here we have a statement, it's really a case description by Colonel Southard, who was an American colonel and a physician in the First World War. And in this instance, he's describing the symptomatology of an American corporal. Fellow was first, he saw his friends killed when a shell hit their trench, and then he was buried alive. Now they dug him out, and he was really not harmed physically, but if you look at his symptomatology, there's a very clear startle reaction, a startle response, which is one of the hallmarks of combat-related PTSD. Of course, Sigmund Freud was no stranger to PTSD. He referred to it as war neurosis, and there you see he tried to actually provide an explanation, we might call that etiological formulation, to try to account for why people do develop PTSD. And again, this is not new. This was actually published in 1919. The point I'm trying to get through is that this is really nothing new. It's been around for centuries, and if one goes back, you can certainly find all sorts of historical accounts of the problem. All this came to a head, though, around 1980, when the American Psychiatric Association's Diagnostic and Statistical Manual, the third edition, actually recognized post-traumatic stress disorder as a formal psychiatric classification. Before that, it had gone by various names. And to review with you what we're talking about, the principal thing is that a person should have been exposed to what's considered a recognizable stressor. And here's what they say about it. The person has experienced an event that's outside the range of usual human experience, and that would markedly be distressing to almost anyone. And they give us some examples. Okay? So we're not just talking about a small accident on the freeway or a divorce. We're talking about some major league things. The 1987 Diagnostic and Statistical Manual, called the DSM-IV, presents the following to make that diagnosis. Of course, again, the first thing is that the person should have been exposed to a traumatic event, and subsequently we have symptomatology. The traumatic event is re-experienced, people have flashbacks, they keep on thinking about it while they're awake, or they can have nightmares. Very frequently, people with PTSD, well, not frequently, they will avoid stimuli associated with a trauma. People avoid things which remind them of what happened to them. And subsequently also, there can be a whole set of symptoms which weren't apparent before the problem, such as irritability, anger, guilt is a big one, and memory impairments, specifically things like concentration impairment. You can't recall information, phone numbers, etc. All right, that's the current classification as put forth by the American Psychiatric Association. Let me also say, though, that when PTSD was recognized as a formal entity, and even before that, in 1980, there was a good deal of opposition by a number of groups who claimed it was a fictitious disorder, it wasn't a relevant disorder, it was part of other disorders, and it really shouldn't be recognized as a distinct, separate psychiatric entity. Well, a lot of research subsequently was directed towards what I call the validation of the model, trying to determine or really establish that people who meet criteria are different than others. One of the first empirical studies which looked at that was a study by John Fairbank and Terry Keane. And the data which I'm showing you, I'll just try to explain it to you briefly, involved three groups of subjects. The first one, of course, were Vietnam veterans with post-traumatic stress disorder. The second was a rather heterogeneous group of patients with psychiatric problems. And the third involved Vietnam veterans without psychiatric problems. And they took a bunch of tests, like the BDI, that's a Beck Depression Inventory, it's a test of depression. They took an anxiety scale, fact, they took 3 anxiety scales and 2 depression scales. And if you just look at that, we can see that the scores, the averages of the Vietnam veterans were significantly and clinically greater than those of the other groups, which tends to support distinctly that Vietnam, the classification as a diagnostic entity, has considerable validity. Now, there have been really a lot of studies done. I just picked 3, which I feel are rather important. The slide which I'm showing you now was conducted by Ed Blanchard and Lawrence Kolb, who was an extremely eminent psychiatrist involving Vietnam veterans in Albany. Now, in that study, we have 2 groups of patients: Vietnam vets with PTSD and those without. And what they did was they put a heart rate monitor on both groups. And initially they had a baseline. They just had the people listen to some soft chamber music. Then there was some silence. They played some more music. And then they had them watch a videotape of a combat scene out of Vietnam. It's a very realistic combat scene with sounds, all the sounds, the shelling, the screaming, the whole bit, and the sights, which are indicative of combat. Now, the data on the top, you can see the Vietnam vets with PTSD really had markedly higher heart rates than those who did not have PTSD. And it's also interesting that the Vietnam vets from the beginning had higher heart rates before the treatment even began. But when the combat tape was played, you can see a major acceleration in heart rate, which would again support the validity of the classification. I'd also like to point out that PTSD is not limited to combat veterans. People develop PTSD after being exposed to a traumatic event. Women have PTSD after being raped. People can have PTSD after natural disasters, such as what happened in San Francisco. I certainly expect there's going to be a lot of people in San Francisco as a function of the earthquake who are going to have PTSD, and children can have PTSD. This is a slide involving children, data which I collected in Beirut. The first group, the white, are children with post-traumatic stress disorder. The second group had simple phobias like test phobia, and the third group really didn't have any psychiatric problem. And if you just look at the bar graphs, you can see that children with post-traumatic stress disorder have markedly higher levels of anxiety, depression, and misconduct than other children, which again really supports the classification. Well, I think it's appropriate to then we come to the next thing. The question is, and I think this, of course, this relates to you, what about the children of Vietnam veterans? Can parental PTSD affect children? That's the issue. And as a psychologist on the staff of a psychiatry service at the VAMC, Barbara Simmons and I were conducting and have been conducting a study. And it involves Vietnam veterans, and that's what we're really trying to determine. Really, if parents have PTSD, does it affect their children? I'm going to be showing you some very preliminary data. The study is not complete, but I do have enough cases where I feel justified to talk about it. In doing this study, we identified Vietnam veterans who have PTSD and who do not have currently substance abuse or alcoholism. We're talking about PTSD. After identifying them and getting their permission to do the study and we sought and obtained the permission of their children to conduct the study. The issue is we want to test their kids, and we did. And we looked at 4 parameters. The first is the anxiety level of the children. And if you just look at that bar graph, we're comparing the level of anxiety of the kids whose parents have PTSD to a national average on that particular test. And not to get too statistical and talk about things like Mancova and things like that, but you can see there is a difference, and it's a big difference. Okay? But that's not the whole thing. Let's look at depression. And again, there's a pretty marked difference. We looked at anger, and these children are really pretty angry vis-a-vis the average. And finally, we looked at misconduct, and you can see a major difference there. Well, it's too soon to take a formal position. I'd like to take a tentative position, which is the data suggest that parental PTSD can have a major negative influence on children. Now, if that's true, if it's true, of course, I would recommend that the government needs to recognize this and to provide needed services, if it's true. But, as a researcher, and I have to make some comments. We have to draw caution, really. First of all, this is group data, and group data consists of averages. And averages can mask meaningful individual differences. And to put that in plain parlance, there are many Vietnam veterans with PTSD who have well-adjusted children. And you should not look at this and say, well, since I have PTSD, my kids are messed up. That is not necessarily correct. Okay, these are just averages. And many of the veterans who we tested, their children were quite normal and they didn't have any sort of problems. But, as I told you, this is a very tentative study. I'd like to, at this point, in fact, I'm going to ask for your help. If you are a Vietnam veteran and you're not really currently on drugs or alcohol, and if you have any children, adolescent children, I'm going to distribute a sign-up sheet. And what this is going to involve is the following. You'll sign the sheet and also give us your phone number, and we'll call you to set up an appointment. Now, when you come in,
I'd like to cite is also a sign-up sheet outside on the desks that we've been using this morning.
lovely. Thank you very much, Mac. Thank you very much indeed. We'll call you, set up the appointment, we'll explain the study, and we'll get your consent in writing before proceeding. We'll also get the consent of your wife, spouse, and the children before proceeding. After we get all these consents, we'll distribute forms for the children to fill out. I'll get these are tests. They're anxiety tests, depression tests, anger, misconduct. We score the tests here at the VA, and subsequently we'll contact you to give you the results. And we'll let the kids know if there is a problem as well. If there is a problem, we'll make the appropriate referral. So not only is this a study, a research study, but I really think, frankly, it does offer an excellent opportunity. It provides clinical services to you and your children. So it's just not a research study which is going to be a report somewhere. We would like to see if the kids do have a problem. If you do it, we're going to let you know about it, and we'll suggest where you can seek help. Okay, Matt kindly suggested that there are sign-up sheets. Again, I would like to have your help, and since the sheets are outside, I won't pass these out now, but if you're interested, please sign them. Yes? One, I'm not writing a book. Okay. It's not. I appreciate your question. I understand your concern. let me assure you, yeah, I know, but I'm trying to answer your question. Well, my direct answer is no. I don't intend, and I will not write a book on this study. Okay? If I do this, it's going to be an article in a journal which nobody gets paid for. And that's the bottom line. My intent is, the agenda is, one, to provide a needed service for the community. Okay? If you went out to a private practice and got this, asked to have these assessments, it would cost a good deal of money. And two, if there is a problem which the children of Vietnam vets are having as a function of their parents' problem, I'm going to try to bring it to the attention of the government. Okay? That's what I could do. Writing a book, believe me, no, I have known, book publishers would not write a book on this topic. If they do, that's fine, but I assure you that's not my agenda. I have no intention of doing that. Thank you for the kind question, though. Okay, having said that, as a psychologist and a child psychologist, let me talk a little bit about some of the problems which children have, and these are the sort of problems which clinicians see. The major thing which child psychologists, or if you want to call them pediatric psychologists or school psychologists, see involve negative behaviors. And basically, we're talking about tantrums. Children don't obey. They're quite demanding. They're also, the second major problem are school problems. And of course, the major thing here are poor marks. Also, children may dislike the school. There also may be aggression towards the teacher. Frequently, there is a good deal of truancy. The third major category would involve personality problems, such as lack of motivation, very poor self-esteem, and these can be quite serious. I mean, things start waxing that way. Children and adolescents sometimes do very bad things, self-destructive things. Well, what's to be done? Well, I can make 3 recommendations, and I really thought about this beforehand. I said, well, could I talk to this group and talk about specific therapy techniques? The answer is no, I don't think that's appropriate. But I can suggest 3 things which I feel might help. And they involve reading. First involves reading, and there are excellent materials, source materials, which were specifically developed for parents to read about problems of children and adolescents. And I'm going to distribute these now.
Shania Twain, it's daytime's #1 talk show.
I'm dizzy from that. I'm dizzy.
Watch live
tomorrow morning at 9 on ABC 7.